Hello everyone, so in this video I'll be talking about the various valvular heart diseases like MR, AS, MS and AR and the pathophysiology of the murmurs that occur in them. Before entering into the topic per se, let's see what a murmur means. A murmur is an auscultatory finding that is heard due to turbulent blood flow across a valve. So there are two types of murmurs, namely systolic murmurs and diastolic murmurs. A systolic murmur is one which occurs in between S1 and S2. Basically, the murmur that occurs in systole is called a systolic murmur, and from S2 to the next S1 it's called diastole. So the murmurs that occur during diastole are called diastolic murmurs. So first let's talk about ventricular systole and the various phases of ventricular systole, and then it will be easy to understand why in MR and AS systolic murmurs are produced. So coming to ventricular systole, there are three phases in ventricular systole. Systole means contraction. When the ventricle contracts, it's called systole. So there are three phases, namely isovolumetric contraction, rapid ejection and reduced ejection. Ventricular systole occurs for 0.3 seconds. One cardiac cycle is for 0.8 seconds duration. So if ventricular systole is for 0.3 seconds, then ventricular diastole will be for 0.5 seconds. As we said, there are three phases: isovolumetric contraction, rapid ejection and reduced ejection. Now let's try to understand what isovolumetric contraction means. So isovolumetric contraction, what do we understand from the term? Iso means same, volume, isovolume, same volume, and there is contraction of the ventricle. So we have the mitral valve here between the left atrium and the left ventricle, and we have the aortic valve between the left ventricle and the aorta. So now let's see what isovolumetric contraction means. The left ventricle will contract against two closed valves. So the mitral valve and the aortic valve will be closed and left ventricle will contract. So if it's contracting against closed valves, what will happen? Blood won't come in because the valve is closed, and blood won't go out because the aortic valve is closed. So there is neither entry of blood nor exit of blood from the left ventricle, but the left ventricle will contract. So there is increase in the pressure, but there is no change in the volume of blood. There is increase in the pressure, there is no change in volume. Volume remains same. So it's called isovolumetric contraction of the left ventricle. Similarly, the process happens in right ventricle. But now let's see about the left side of the heart. Okay, so what is rapid ejection and what is reduced ejection? So at the end of isovolumetric contraction, because of the increase in the pressure in the left ventricle, the aortic valve will open. Aortic valve opens, so blood will now go from the left ventricle to the aorta, because the aortic valve will open. So this is called as rapid ejection, and 2/3 of the blood in the left ventricle is ejected from left ventricle to aorta by this process. And during reduced ejection phase, the remaining 1/3 of blood from the left ventricle will go into the aorta. Now at the end of systole, there will be around 50 ml of blood remaining in the left ventricle. This is called end systolic volume. It's important to know that the heart cannot eject out all the blood. There has to be some blood remaining in the ventricle at the end of systole. This is end systolic volume, which is 50 ml. So we understood what is isovolumetric contraction, where the left ventricle contracts against two closed valves. So there is no change in the volume, but there is increase in the pressure in the left ventricle. So the aorta will open, and during rapid ejection, blood will rapidly grow from the left ventricle to the aorta. Similarly, during reduced ejection, the remaining 1/3 of the blood will go from the left ventricle to the aorta. So this is what is all about systole. Now let's understand the two conditions which cause systolic murmurs. First, let's talk about mitral regurgitation. What is mitral regurgitation? To understand that, you have to know that the mitral valve can be affected in case of rheumatic heart disease or Marfan syndrome most commonly. So what happens? Rheumatic is the most common etiology for mitral regurgitation. It's important to know that acute rheumatic fever most commonly causes mitral regurgitation, whereas rheumatic heart disease most commonly causes mitral stenosis. Okay, so what is mitral regurgitation and why does it happen? So we know there are two cusps in the mitral valve, and there is something called a mitral valve prolapse because of the valvulitis in rheumatic fever. Because of the valvulitis in rheumatic fever, and over time there is fibrosis and calcification. So because of the acute inflammation or the valvulitis in rheumatic fever, what happens is that the leaflet, one of the leaflets or both the leaflets of the mitral valve will go into the left atrium. So if it goes into the left atrium like this, and when it tries to close, there will be a gap in between the two leaflets. It goes into the left atrium like this. This is called mitral valve prolapse. So this leads to mitral regurgitation. There is an annulus or a ring around the mitral valve. So when there is left ventricular dilatation due to some cause, the annulus or the ring will also dilate. Or when there is papillary muscle, we have papillary muscles over here. When the papillary muscles are affected, are injured, especially in myocardial infarction, for example. So what happens when the papillary muscles are injured, or when the ring dilates, or when the mitral valve prolapses? There will be a leaky mitral valve. Even when the mitral valve tries to close, there will still be a gap between the two cusps. Okay, so now let's talk about ventricular systole in the case of mitral regurgitation. So there are three phases. We know isovolumetric contraction, rapid ejection, and reduced ejection. During isovolumetric contraction, what happens? The left ventricle will contract against two closed valves, which are the mitral and the aortic valve respectively. But now this mitral valve is not closed fully, it is still open. So when the left ventricle contracts, the blood cannot go through the aortic valve because it's closed. Whereas the mitral valve is open, it's floppy or it's leaky. So blood will go from the left ventricle to the left atrium during isovolumetric contraction phase. Next, we have rapid ejection and reduced ejection. In rapid ejection phase, aortic valve will be open, so blood will be going from the left ventricle to the aorta. But also the blood will again be going from the left ventricle to the left atrium through the open mitral valve. Similarly, during reduced ejection phase, blood will go from the left ventricle to the aorta, and it will also go to the left atrium. You also know that in the heart, blood flows from a region of high pressure to a region of low pressure. When the ventricle contracts, obviously there will be high pressure, so it will go to the left atrium and also to the aorta. So what do we see? During all the three phases of ventricular systole, isovolumetric contraction, rapid ejection, reduced ejection, during all the three phases, blood is going from the left ventricle to the left atrium. During the entire length of the systole, blood is going from the ventricle to the atrium. Blood is regurgitating, it's going back. So this is called as a pansystolic murmur. Pansystolic means during the entire length or during the total length of systole, blood is going from the left ventricle to the left atrium. So now we can see the murmur of mitral regurgitation. Between S1 and S2 is what is called systole, and during the entire length of the systole, during all the three phases, blood is going from the left ventricle to the left atrium. There is turbulent blood flow, so we hear a pansystolic murmur. There is no murmur during diastole. Now, why have we drawn the S2 so thick? This is to indicate pulmonary artery hypertension. So in mitral regurgitation, we know that blood is going from the left ventricle to the left atrium. So already there will be blood coming to the left atrium from the pulmonary veins. Now again blood is going from the left ventricle to the left atrium during each ventricular systole. Because of this, there is increased amount of blood in the left atrium. So over time, the blood from the left atrium will go through the pulmonary veins to the lungs, and there will be pulmonary venous hypertension, and the pressure is transmitted to the pulmonary capillaries and to the pulmonary artery. So there will be pulmonary artery hypertension. So that is very important, and that is the reason why I have marked S2 as a thick box. That is why there is loud S2. Next, let us talk about aortic stenosis. So what is stenosis? Stenosis means narrowing of a valve. The most common cause for aortic stenosis is rheumatic heart disease in younger individuals, whereas in older individuals above say 55-60 years old people, they have something called aortic sclerosis, where there is atherosclerosis and calcification. That's mainly calcification of the aortic valve. So aortic valve is a tricuspid valve. So what happens in aortic stenosis? Blood from the left ventricle will actually go to the aorta through the aortic valve during systole. So now what happens when the valve is narrowed? There will be reduced space for the blood to go from the left ventricle to the aorta. Now we know there are three phases in ventricular systole: isovolumetric contraction, rapid ejection, and reduced ejection. We saw in mitral regurgitation, blood is going from the left ventricle to the left atrium during all the three phases. Whereas in the case of aortic stenosis, blood will go from the left ventricle to the aorta only during two phases: the rapid ejection phase and the reduced ejection phase. Because during isovolumetric contraction, the aortic valve will be closed. Only after the end of that phase, it will be open. So during rapid ejection phase, when the aortic valve opens, blood will go from the left ventricle to the aorta. but the valve is narrow, so there will be turbulent blood flow. And during reduced ejection phase, again blood is going from the left ventricle to the aorta. So this is heard as a ejection systolic murmur. It's a systolic murmur because there is turbulent blood flow across a valve during ventricular systole. So it's a systolic murmur. Ejection systolic murmur during the rapid ejection and reduced ejection phases of ventricular systole. We can see that the blood is going turbulently from the left ventricle to the aorta. So during the ejection phase, it's called ejection systolic murmur. Now let's look into the murmur. You can see that the murmur occurs during systole. Between S1 and S2 is systole. The murmur is occurring during systole, and it's a crescendo-decrescendo murmur. Crescendo-decrescendo type of ejection systolic murmur is heard in aortic stenosis. I hope this was clear. Now let's try to understand the various phases of ventricular diastole and the two valvular heart diseases associated with diastolic murmurs, mitral stenosis and aortic regurgitation. Now coming to ventricular diastole, first let's understand what diastole means. Diastole means relaxation. Ventricular diastole means relaxation of the ventricle. During systole, the ventricle will eject out blood, and during diastole, it will receive blood. Okay, so the ventricular diastole lasts for 0.5 seconds. One cardiac cycle is for 0.8 seconds, which consists of ventricular systole for 0.3 seconds and ventricular diastole for 0.5 seconds. Now, there are 5 phases in ventricular diastole. Protodiastole. Proto means beginning. Protodiastole means beginning of diastole. Isovolumetric relaxation. Isovolume. We know what isovolume means. It means the volume of the ventricle doesn't change. In systole, we saw there was something called isovolumetric contraction phase. Now here in ventricular diastole, we have isovolumetric relaxation phase. Okay, then we have rapid filling, reduced filling, and the last phase, which is called atrial kick or contraction. Now let's get into each phase. We have 5 phases: protodiastole, isovolumetric relaxation, rapid filling, reduced filling, and atrial kick or contraction. Protodiastole means beginning of diastole. So what is systole and what is diastole? Systole occurs between S1 and S2. Diastole occurs between S2 and the next S1. In the beginning of diastole means diastole occurs from S2 to S1. In the beginning of diastole, there is S2 occurring. S2 heart sound is heard, which means what is S1 and what is S2? S1 is a heart sound that occurs due to the closure of the atrioventricular valves, which are the bicuspid and the tricuspid valves. The bicuspid is also called the mitral valve. Because of the closure of mitral and tricuspid valve, we hear S1 heart sound. And S2 heart sound is heard because of the closure of the semilunar valves. Semilunar valves are nothing but the aortic and the pulmonary valves. So, in the beginning of diastole phase, S2 occurs. Nothing but closure of the aortic valve occurs, aortic and pulmonary valves. So, that is called protodiastole. Coming to isovolumetric relaxation. In isovolumetric relaxation phase, what happens is the ventricle will relax. Isovolumetric. Ventricle will relax against two closed valves. Mitral valve and aortic valve are closed, and the ventricles will relax. So this is called isovolumetric relaxation. In isovolumetric contraction, we know since there is the ventricle contracting, there is increased pressure in the left ventricle and the right ventricle. But over here, the ventricle is relaxing, so the pressure in the ventricles will reduce. Pressure in ventricles will reduce, but the volume remains the same. This is known as isovolumetric relaxation. Next, we have rapid filling phase, reduced filling phase. Okay, so what is rapid filling phase? Rapid filling phase and reduced filling phase are both passive processes where the mitral valve will open and there is rapid filling followed by reduced filling of blood from the left atrium to the left ventricle. Now, this filling occurs due to the opening of the mitral valve. In heart, we know blood always flows from a region of high pressure to a region of low pressure. In isovolumetric relaxation phase, what happens? The ventricle will relax, the pressure reduces. So next phase is rapid filling. So there is reduced pressure in the left ventricle and there is increased pressure in the left atrium compared to left ventricle. Because it's relaxing, the pressure reduces. So left atrium has high pressure, and due to a passive process called rapid filling, because of the opening of the mitral valve, blood goes from the left atrium to the left ventricle. Next, reduced filling, remaining blood goes from the left atrium to the left ventricle. The rapid filling and reduced filling account for almost 80% of blood from the left atrium entering the left ventricle. The remaining 20% of blood will have to be ejected from the left atrium to the left ventricle by an active process called atrial kick or contraction. The atria will contract actively so that the remaining 20% blood goes from the left atrium to the left ventricle. The end diastolic volume is around 120 ml. So now we understood the various phases of ventricular diastole. Let's talk about mitral stenosis. We know stenosis means narrowing of the valve. The most common condition which causes narrowing of the mitral valve is rheumatic heart disease. So in rheumatic heart disease or acute rheumatic fever, the mitral valve will undergo inflammation, which is also called valvulitis. Because of the valvulitis, the healing is produced by fibrosis. The healing occurs because of fibrosis. So when the valve is fibrosed and the valve is calcified, what happens is it will become narrow. There will be, even if the mitral valve opens, there will be a very small gap for blood to enter from the left atrium to the left ventricle. So the valve will be very narrow or stenosed. This is what happens in mitral stenosis. Now what kind of murmur will be heard? We know blood from the left atrium will enter the left ventricle during diastole. So blood from the left atrium will enter the left ventricle during diastole, and during diastole there will be turbulent flow of blood from the left atrium to the left ventricle because of a narrow or a stenosed valve, mitral stenosis. So there is a narrowed valve and turbulent blood flow occurs from left atrium to left ventricle. So this produces a diastolic murmur, and there are a lot of components in the murmur of a mitral stenosis. Let's try to understand them one by one. This is how a murmur of mitral stenosis is represented. There is a loud S1, there is no murmur between S1 and S2, so there is no systolic murmur, whereas there is a murmur between S2 and S1. There is something called opening snap, and the murmur is a mid-diastolic murmur with pre-systolic accentuation. So I'll be explaining everything which I said now. So we know S1, there is a loud S1. It's represented by a thick box, loud S1. Now why does this loud S1 occur? I'll tell you, but before that, there's a loud S1, there's no murmur between an S1 and S2. There is something called an opening snap, which is nothing but a diastolic sound at the beginning of the murmur. So this is the murmur. There is a mid-diastolic murmur. Diastole is from S2 to S1. In the middle of diastole, there is a murmur. So this is a mid-diastolic murmur, and there is a pre-systolic accentuation or increase in intensity of the murmur. Before the systole, there is accentuation or increase in intensity of the murmur. This is called pre-systolic accentuation. So why does a loud S1 occur in mitral stenosis? We know after diastole, the mitral and the tricuspid valves will close. But in the case of mitral stenosis, there is increased pressure in the left atrium. There is increased volume of blood in the left atrium, increased pressure. So what happens is that the mitral valve leaflets are wide apart and they have to come and close from a greater distance. So the closure of the mitral and the tricuspid valve is basically the first heart sound, and since they have to close from a greater distance, so a loud S1 is heard. Then what is this opening snap? It's nothing but a diastolic sound that is heard just before the murmur is heard. There is a mid-diastolic murmur, and it's usually heard with the bell of the stethoscope in left lateral position of the patient. So loud S1, opening snap is heard. That's nothing but a diastolic sound just before the murmur is heard. There's a mid-diastolic murmur, and there's a pre-systolic accentuation. Before systole, S1 and S2 is systole. Between S1 and S2 is called systole, and before systole there is a pre-systolic accentuation or increase in intensity of the murmur. Now, why does this accentuation happen? I think because of the last phase of diastole, which is atrial kick or contraction, there is forceful contraction of the atria. There's forceful contraction of the left atrium, and it pushes the blood into the left ventricle. Because of this, there is a pre-systolic accentuation, last phase of diastole. So there is one condition where the S1 won't be loud, it will be soft. This is because of a calcified mitral valve. Because of a calcified mitral valve, there won't be a loud S1. Okay, now how do we know if the person with mitral stenosis is worsening? In worsening of mitral stenosis, the S2-OS interval is narrow. So now there is some space between S2 and OS. OS is nothing but a diastolic sound. Now if the patient worsens, what happens is the OS, which is heard over here, comes very close to the S2. But clinically identifying opening snap is difficult, and to recognize that the interval between the S2 and OS is reduced is all the more difficult. So how to identify that the disease is worsening in mitral stenosis? we know that when the opening snap actually comes closer to the S2, the murmur will also come closer. So which means the murmur will be heard for a longer duration. When the opening snap is heard over here, the murmur also is heard over here. When the duration of the diastolic murmur is increased, it means the patient is worsening. Coming to the last valvular heart disease, aortic regurgitation. There is a defective aortic valve which is leaking blood into the left ventricle. So now during diastole, we know there are 5 phases: protodiastole, isovolumetric relaxation, rapid filling, reduced filling, and atrial kick or contraction. So during diastole, normally during isovolumetric relaxation, what happens? The left ventricle will relax against 2 closed valves, and the pressure in the left ventricle will reduce because of relaxation. But now the aortic valve is not closed anymore. There is a gap between the aortic valve, and blood is regurgitating from the aorta to the left ventricle. So during diastole, when the left ventricle is relaxing, there is flow of blood, there is actually leaking of blood from the aorta to the left ventricle, and there is turbulent flow. This is a turbulent flow of blood from the aorta to the left ventricle during diastole. This is heard as a early diastolic murmur. We know that blood always flows in the heart from a region of high pressure to a region of low pressure. So aorta has high pressure and the ventricle is relaxing during diastole. So there is low pressure. So blood goes from the aorta back into the left ventricle. Blood is coming from the left atrium to the left ventricle. Similarly, blood is also coming through a leaky aortic valve from the aorta to the left ventricle. So there is increased amount of blood in the left ventricle during diastole. But during systole, what happens? There is increased volume of blood in the left ventricle. So the left ventricle tries to work hard. It tries to forcefully contract, and there is it creates a high pressure so that it can push blood across the high pressure aorta. Normally the pressure in the aorta is 120/80 mmHg. If there is increased volume in the left ventricle already, because during diastole blood was leaking from the aorta also, in additional to the blood that was coming from the left atrium to the left ventricle, there is increased volume of blood. So the left ventricle contracts against a higher pressure aorta. So the pressure in the left ventricle should be more than the pressure in the aorta to push blood from a high volume area to aorta. Systolic BP for a patient with aortic regurgitation will be very high, like 180, 200 in that range. During diastole, the left ventricle should relax against 2 closed valves, but diastolic runoff occurs where the blood from the aorta through a leaky aortic valve comes back to the left ventricle. We measure the pressure of a brachial artery, usually in upper limb blood pressure. So that pressure is reflective of aortic pressure, which is 120/80 mmHg. Diastolic pressure is 80 mmHg. Whereas some blood from the aorta is going back into the left ventricle. So the diastolic BP will be less in the case of aortic regurgitation, as some blood is going back to the left ventricle. The blood entering the aorta is less than usual. So the diastolic blood pressure in the case of aortic regurgitation will be less, and the systolic blood pressure will be very high. To describe the murmur of aortic regurgitation, it's an early diastolic murmur. It's a decrescendo type of murmur. Early diastole, because S2 to S1 is called diastole. In the beginning of diastole, you are hearing it. It's an early diastolic decrescendo murmur.